Hello, everyone. My name is Huang. I'm a doctoral graduate from the University at Albany. Today, I'm thrilled to present to you our research on simulating a multi-tier intervention for refugee mental health using agent-based modeling. Our research objectives are to simulate the most relevant risk and protective factors of mental health outcomes for refugees aged 15 to 64 years who were settled in New York City in 2019 to 2023, and the status quo of the relevant existing resources and infrastructure in New York City for refugee mental health using agent-based modeling. Also, we aim to simulate a multi-tier mental health intervention and investigate the potential effects of 7 different implementation schemes of the MHPSS model on depression and PTSD prevalence and average post-traumatic growth score. Let's start with the main findings from the study for the time purpose. First, under the status quo model, we found that 31% of the simulated agents had depression and about 41% had PTSD. On average, across each 6-month interval during the 5-year study period. Combined interventions can achieve more to reduce refugee depression and PTSD prevalence than any intervention implemented in isolation. We also found that balancing the effort to expand service reach and the effort to improve service effectiveness is more efficient than focusing on improving mental health service effectiveness alone. However, increasing referral rates alone, even to the maximum degree, is not effective. And by the way, this only includes referrals at the initial refugee mental health screening at their arrival. Dose response effects were seen when scaling up the intensity of the multi-tier intervention. However, there are more marginal effects in single-tier interventions. And marginal effects here means that the effects are not linear. You may invest a lot of resources but get very little improvement in the outcome. Considering resources, time, and cost, public health practitioners could use the simulated results to plan multi-tier interventions to address specific goals in refugee mental health. So let's take a step back to give you a brief introduction. There are more than 35 million refugees worldwide. More than 114,000 resettled outside of the home country in 2022, and the US has admitted more than 600,000 in the past decade. New York City is home to more than 5,000 refugees from more than 50 countries. Refugees have 3 to 10 times higher risk of depression and PTSD compared to their counterparts in countries where they resettle. Complex multi-tier interventions were recommended, but their effectiveness was unclear due to the lack of evaluation data. The MHPSS intervention is an example of multi-tier interventions, which refers to concurrent care systems that are comprised of 4 tiers. The tiers are based on the concept of triage matched with the level of mental health screening outcomes. We used agent-based modeling as the main method in the study, which is a computational modeling technique that simulates behaviors and interactions of autonomous individuals, so we can better understand the emergent properties of a complex system. ABM is famous for shortening the feedback cycle of interventions. It can also predict long-term effects with little cost in the research. It's been widely used in public health and mental health research. In the agent-based model, the agents represent adult refugee individuals living in New York City. They have a list of attributes including demographics, mental health scores, stressors, social support, and physical location representing their residency on the map. The New York City map was divided into 71 community districts, and there are 2 types of providers, including community-based organizations and mental health providers. The map on the right side is the simulated map. You can compare it to the map on the left, which is the actual map of New York City. So the simulated map has red dots representing the agents, blue dots, the hospitals providing mental health services, and green dots are the community-based organizations providing refugee support services. Each time we ran the model, the locations of the red dots look a little different. An agent's likelihood to receive service is relevant to their distance to the providers, their mental health status, and other factors. In this conceptual map, you can see that mental health outcomes are directly affected by individual characteristics, social support, and service utilization. The blue boxes are the interventions at different tiers. You may see Tier 1 and 2 services are affecting mental health outcomes indirectly, while Tier 3 and 4 services have direct effects. So we simulated the status quo of refugee mental health status for each of the 695 refugee agents and relevant resources in New York City, along with overall 7 intervention schemes. And each of these schemes were trialed in several different scales. Namely, these schemes are increasing mental health service referral rates, increasing the number of existing service program providers, and increasing the overall effect sizes of the current interventions for depression and PTSD. Then we tested the combination of 2 or 3 of these schemes. This graphic shows you the result of the PTSD outcomes. Stars indicate significant reduction in average PTSD prevalence during the 5-year study period. As for single-tier interventions, increasing overall service effectiveness can bring down PTSD by 7.4%. As you can see here, combinations work better than single interventions. Combining a 200% increase in referral with a 50% increase in service effectiveness yielded a similar result as increasing service programs by 30%, combined with a 30% increase in service effectiveness. Combining 3 interventions yielded the largest reduction in PTSD, as expected. However, when we look at depression results, only the combination of interventions with an intense implementation scale predicted the significant results. Public health leaders should base their selection of interventions on specific goals, resources, time, and cost. If the project goal is to significantly reduce both depression and PTSD prevalence among the refugee adults within 5 years, the decision makers should choose the scheme that combines 3 interventions. The ABM simulation had established the necessity to invest in the service effectiveness, availability, and referral rates at the same time for a more comprehensive goal in improving refugee mental health. At the end, I would like to thank all my co-authors who are also my dissertation advisors. And to you who are listening, let's connect via email or LinkedIn. If you are interested in knowing more about this study, please scan the QR code for a complete list of references, or email me with any questions you have. By the way, I'm also attending the APHA conference in person, so I hope to see you there. Thanks.